Welcome to the Deep Dive. Today, we're venturing into the fascinating and honestly incredibly vital world of cardiac health and medical procedures.
Yeah, we've got quite a collection of insights here, pulled from some pretty detailed medical texts.
Exactly. And our goal, really, is to pull out the most crucial bits, the interesting stuff, and serve it up so it's clear, engaging, maybe give you a few of those, aha moments.
Absolutely. Look, this stuff can be dense, no doubt about it. But our mission today is to make it accessible. We want to distill that core knowledge so you can grasp these important ideas without getting totally bogged down in the technical jargon.
Think of us as your guides through these sources.
We're aiming to help you understand what they're really saying.
Right. Consider this your shortcut to getting up to speed on key things in cardiac care. Everything from, say, preventative steps,
Which can make a massive difference.
to the really nuanced calls made during, critical moments in surgery. Okay, let's jump in. First up, a topic that's seen some pretty big shifts. Preventing infective endocarditis, i.e.
Right, i.e. And what's really interesting is how the understanding of the risk, and therefore the guidelines, have evolved. Back in 2007, the American Heart Association put out revised recommendations about antibiotic prophylaxis.
So taking antibiotics beforehand to prevent infection.
Exactly. And the big change was it's just not the automatic thing it used to be for certain procedures.
Yeah, I think some people might remember always getting antibiotics before, like a dental cleaning. That's changed then.
It has, generally speaking. Routine prophylaxis isn't typically recommended anymore for elective GI or GU procedures, so gastrointestinal or genitourinary. That's quite a shift in thinking.
It really is. Why the change?
Well, the focus became much more targeted. It's about weighing the actual risk versus the benefit more carefully. Overuse of antibiotics is also a concern. So the guidelines zeroed in on specific heart conditions where the danger from getting IE is significantly higher.
Okay, so those are the cases where antibiotics before certain procedures, like dental work, are still considered a good idea. So who falls into that category now? Which conditions?
Okay, the main ones are patients with prosthetic cardiac valves.
Artificial valves. Makes sense. Bacteria might stick to those easier.
That's the thinking, yeah. Also, anyone who's had IE before, they're at higher risk of getting it again than certain types of congenital heart disease. The source just says several types.
Okay.
And finally, cardiac transplant patients who've developed problems with their heart valves, what we call valvulopathy. So it's a much more defined group than it used to be.
Right, identifying those with a clearly higher risk. And if someone is in that group, what's the usual antibiotic plan before, say, a dental procedure?
The common recommendation is cephalexin, 2 grams orally, or an equivalent dose of another similar oral cephalosporin.
And if they're allergic?
Then clindamycin, 600 milligrams, is an option. That can be given orally or by IM or IV injection. And the timing's important, too. It needs to be given 30 to 60 minutes before the procedure starts.
Got it. Specific conditions, specific drugs, specific timing, very precise. And the source gives a good example to illustrate this selectivity, doesn't it?
It does. It specifically mentions that a patient with aortic stenosis, just standard aortic stenosis, does not routinely need prophylaxis.
Okay. So just having a heart condition isn't enough. It has to be one of those specific higher risk ones we just listed.
Exactly. It really shows how selective the guidelines are now.
That's really helpful. Okay, let's switch gears pretty dramatically. Heparin-induced thrombocytopenia type 2, HIT type 2. That name itself sounds, well, backwards, considering heparin is an anticoagulant.
You're absolutely right. It seems paradoxical. Heparin is meant to prevent clots, but in HIT type 2, it actually triggers a serious drop in platelets.
Platelets, the clotting cells.
Right. The count typically falls 5 to 10 days after starting heparin, and it can be a big drop, often below 100,000 per cubic millimeter, or less than half what the patient started with.
Wow. And the source mentioned paradoxical thrombosis. Clotting. That sounds really dangerous.
It is. It's deeply concerning because despite the low platelet count, these patients are actually at a higher risk of forming new clots, both arterial and venous.
How does that even happen? Low platelets, but more clots.
It's complex, but essentially an antibody forms against a complex of platelet factor 4, PF4, and heparin. This antibody PF4 heparin complex then binds to and activates the remaining platelets, making them clump together and form clots.
So the body's immune response to heparin backfires, causing clots?
In a nutshell, yes.
Yeah.
That's why monitoring platelet counts so closely in anyone getting heparin is just critical.
And how do doctors confirm it's HIT type 2? Is there a specific test?
Yes. Serologically, they test for those specific antibodies to the PF4 heparin complex. Finding those antibodies in someone with dropping platelets after heparin exposure is key to the diagnosis.
Now, managing these patients if they need surgery, especially something major like cardiopulmonary bypass, that sounds like walking a tightrope.
It's incredibly challenging. Ideally, you'd wait until those antibodies disappear before surgery.
But that's often not possible in emergencies.
Right. Exactly. So the big question becomes, how do you anticoagulate them during bypass when heparin is the usual go-to drug, but you can't use it?
What are the alternatives then?
There are a few options. Direct thrombin inhibitors like bivalirudin or lepirudin. Another one is danapuroid, which inhibits factor XI.
Okay.
Interestingly, the source also mentions potentially using unfractionated heparin, the standard kind, but only if you combine it with another drug to prevent the clotting, something like tirofiban or ipoprostenol, which work on platelets.
So maybe still use heparin, but with extra protection against the HIT clotting risk.
That's the idea in some carefully managed scenarios, yes. The goal is anticoagulation for the bypass machine without triggering more HIT clots. It's also worth noting, fondaparinux, another drug sometimes used, is specifically not recommended for bypass in HIT patients, according to the source.
Good detail. What about plasmapheresis? Where does that fit in?
Ah, yes. If you have time before surgery, plasmapheresis can be done. It's basically a procedure to remove the patient's plasma, which contains those harmful antibodies, and replace it. It helps reduce the antibody load.
Okay, that's a really good rundown of a complex problem. Let's shift again. Myocardial ischemia, lack of blood flow to the heart muscle. What are the key signs?
Ischemia can show up in different ways, ECG changes, chest pain, but the source here really emphasizes one thing as being the most sensitive indicator among the options listed.
And that is?
Left ventricular wall motion abnormalities.
Wall motion. So how the main pumping chamber is actually moving, that shows up first.
Often, yes, before you even see clear ECG changes sometimes. Techniques like echocardiography can visualize the heart beating, and you can see if parts of the muscle aren't contracting properly, which is a very early sign of insufficient blood flow.
That's a key takeaway. Functional changes before electrical ones sometimes. Okay, let's define something that sounds a bit technical. Metabolic equivalents or mentees. What's a mentee?
Think of 1-EAT as your baseline energy use. What your body burns just sitting quietly at rest.
Okay, the bare minimum.
Pretty much. Technically, it's the rate of oxygen consumption, about 3.5 milliliters of oxygen per kilogram of body weight per minute.
Can we make that more concrete? The source had an example.
Yeah, for a typical 70-kilogram person, 1 AB equals about 250 milliliters of oxygen consumed each minute.
Right.
So if that same person was doing something more strenuous and using, say, 2,500 milliliters of oxygen per minute...
That would be 10 times the resting rate, so 10 MET.
Exactly. It gives us a standardized way to talk about how much energy different activities demand relative to just resting.
Makes sense. Higher METs mean more work for the heart. Okay, let's talk about patients with congenital heart defects, CHDs. Anesthesia for them sounds tricky.
It absolutely requires a deep dive into their specific anatomy and physiology. You have to understand the pathophysiology of their particular defect. But broadly, you can think about CHDs based on shunting whether blood is abnormally flowing left to right or right to left within the heart.
Okay, two main categories based on blood flow direction. Let's start with right to left shunts. What's the main issue there?
The key feature is that blood flow to the lungs is reduced. So deoxygenated blood from the right side of the heart bypasses the lungs and gets shunted over to the left side, mixing with oxygenated blood and going out to the body.
Meaning the blood going to the body isn't fully oxygenated, arterial hypoxemia.
Exactly, lower oxygen levels in the systemic circulation.
What are some common examples of right to left shunts?
The classic one is tetralogy of Fallot. Others include Eisenmenger syndrome, Epstein malformation, pulmonary atresia with a BSD, tricuspid atresia, even a patent Foreman oval or PFO under certain circumstances.
Quite a list. Now, there's a critical point in the source about anesthesia for these patients, something about air in IV lines.
Yes, this is hugely important. Utmost care must be taken to avoid introducing any air bubbles into their IV lines.
Why is that so crucial for them specifically?
Because of that right to left shunt, Normally, small amounts of air entering the veins would get trapped in the lungs' capillaries. But in these patients, that air can bypass the lungs entirely through the shunt and go directly into the arterial circulation.
Leading to an arterial air embolism.
Correct. Which can travel to the brain and cause a stroke or other serious neurological damage.
Oh.
It's a potential catastrophe.
Wow.
So meticulous de-airing of all IV lines is absolutely non-negotiable.
Wow. A stark reminder. Now, what about the other category? Left to right shunts. Like a patent ductus arteriosus, a PDA, is air embolism a big risk there?
Much, much less so. With a left to right shunt, the abnormal flow is from the higher pressure left side to the lower pressure right side and then towards the lungs.
So any venous air would likely just go to the lungs where it's less dangerous.
Generally, yes. The risk of systemic arterial air embolism is minimal compared to right to left shunts.
That contrast really highlights the importance of the shunt direction. Okay, let's tackle a core concept, the Frank-Starling curve. Fundamental physiology, right? What's it telling us?
It is fundamental. The Frank-Starling mechanism, or curve, describes a basic relationship in the heart. How much the heart muscle fibers are stretched at the end of filling, that's the preload, or end diastolic volume.
The filling pressure, essentially.
Right. It relates that stretch to how forcefully the heart contracts afterwards, the ventricular work or stroke volume. Think of stretching a rubber band. Stretch it more up to a point, and it snaps back harder.
So more filling leads to a stronger beat within limits.
Right.
How do we measure that filling pressure or stretch clinically?
We use indicators like the left ventricular end diastolic volume or pressure itself, left atrial pressure, the pulmonary artery occlusion pressure, the wedge pressure, and sometimes even central venous pressure can give us an idea, particularly about the right side, which often correlates with the left.
And on the other side of the curve, how do we measure the heart's work output, the strength of that snap?
That can be represented by things like stroke volume, how much blood is ejected per beat, the cardiac output, which is volume per minute, the cardiac index, which adjusts output for body size, the left ventricular stroke work index, or even just arterial blood pressure, since that's the pressure the heart is pumping against.
Got it. The relationship between filling and pumping force. Now let's look at an ECG rhythm, atrial flutter. How do we spot that?
Well, the source uses an example rhythm strip showing Slutter with varying conduction, but the absolute key point it makes is you must look at multiple ECG leads.
Why multiple leads? Can't you see it in just one?
Not always clearly. Atrial flutter is characterized by very rapid, regular atrial activity, the flutter, or F waves, often around 300 beats per minute, but in some leads, these F waves might be subtle or hidden.
So you might miss it. The source says it could be mistaken for a junctional rhythm.
Exactly. If you only look at a lead where the F waves aren't obvious and the ventricular response happens to be slow and regular, you might misdiagnose it. But if you look at other leads, you'll usually see those characteristic sawtooth F waves much more clearly.
And how does that super fast atrial rate, like 300, relate to the actual pulse rate, the ventricular rate?
The AV node, the connection between atria and ventricles, usually can't conduct that fast. It blocks some of the impulses, so you get a ratio. Maybe 2.1 block, meaning every second flutter wave gets through, giving a ventricular rate around 150.
Okay.
Or it could be 4.1 block, like in the example rhythm described, where the atrial rate is 300, but the ventricular rate is only 75. Sometimes the block varies, leading to an irregular ventricular rhythm. Seeing those F waves in multiple leads is crucial for the right diagnosis.
Right, you need the full picture. Okay, specific scenario. Pulmonary artery or PA catheter issues during cardiopulmonary bypass. What can happen?
It's actually pretty common for the PA catheter to migrate further down the pulmonary artery during bypass. It can float distally, maybe 3 to 5 centimeters.
Flow deeper into the lung vessels.
Yeah. Because of this, some doctors might even pull it back a bit before going on bypass, just prophylactically.
And how would you know if it's migrated too far, maybe got wedged in a smaller vessel?
The key sign is an unexpected rise in the PA pressure reading. When the tip gets wedged, it reflects the pressure further downstream in the capillaries, which can be higher or look different.
And the source notes this migration is a potential cause of PA rupture. That sounds serious.
It's a known, though thankfully uncommon, complication, a serious risk. But the source also makes an important point about figuring out why the PA pressure might be high during bypass.
It's not always migration.
No. It could also be due to inadequate venting of the lead ventricle, meaning blood is backing up and distending the ventricle.
How do you tell the difference?
If withdrawing the PA catheter slightly makes the high pressure reading go down, it was probably migration, a wedge issue. But if the pressure stays high, even after pulling the catheter back, it's more likely due to the ventricle being too full, not being vented properly.
And why is that ventricular distension bad during bypass? The heart isn't really pumping then, is it?
It's not pumping effectively, but a distended ventricle still has increased wall tension. That increases the heart muscle's oxygen demand, even while it's not getting its normal coronary blood flow from the bypass pump. So it's starving for oxygen at a time of increased need. Very detrimental.
Okay, that makes sense. Increased demand, no supply. Bad news. The source also mentioned issues with the main bypass cannulae, the tubes going into the aorta and veins. What can go wrong there?
Right, cannula malposition. If the aortic cannula, the one returning oxygenated blood, is pointed wrongly, say, up the brachiocephalic artery,
Treating the right arm and head.
you might see unilateral facial blanching. One side of the face looks pale because it's getting all the direct flow.
Okay, and the venous cannula, draining blood out.
If it's pushed too far up into the superior vena cava, it can block drainage from the head and arms. You might see facial swelling, maybe bulging eyes, or sclerae.
Like a dam effect.
Exactly. Conversely, if it's too far down in the inferior vena cava, it might obstruct drainage from the lower body, maybe cause the abdomen to distend. You'd need to pull it back proximally. A well-placed venous cannula should just drain smoothly by gravity when you lower the tubing.
Very practical points. Okay, another congenital defect. Transposition of the great vessels. What's the basic problem?
This happens during fetal development. The aorta and pulmonary artery connections get switched. The aorta comes off the right ventricle, and the pulmonary artery comes off the left ventricle.
The complete opposite of normal. What does that do physiologically?
It creates two separate parallel circuits instead of one continuous loop. The right ventricle pumps blue, deoxygenated blood out the aorta to the body, and that blue blood returns to the right atrium. The left ventricle pumps red, oxygenated blood out the pulmonary artery back to the lungs, and that red blood returns to the left atrium.
So the body never gets oxygenated blood and the lungs keep getting oxygenated blood.
Yeah.
That sounds incompatible with life.
On its own, it is. Survival depends on having some other defect that allows mixing between the two circuits, like a hole between the atria, PFO or ASD, or ventricles, PSD, or a patent ductus arteriosus, PDA. There has to be mixing.
Right. And anesthesia induction for these babies, how does the transposition affect that?
It changes drug delivery dramatically. Inhaled anesthetics, volatile gases, rely on blood flow through the lungs, picking them up and delivering them to the brain via the left ventricle and aorta. Here, the aorta comes off the right ventricle, which gets systemic venous return, not much lung blood flow. So inhaled induction will be very slow.
Takes longer to get them asleep with gas.
Much longer. But intravenous drugs, they're injected into a vein, go to the right heart, and are immediately pumped out the aorta to the brain with minimal dilution in the pulmonary circulation.
So 5E drugs hit faster and harder.
Exactly. You need to use much smaller doses and inject them more slowly to avoid overdose.
Really critical difference. Now the Fontan procedure.
Yeah.
What's that?
The Fontan is a type of surgery, often done in stages, that essentially redirects venous blood from the body directly to the pulmonary arteries, completely bypassing the right ventricle.
So blood goes straight from the body veins to the lungs without passing through a pumping chamber on the right side.
Correct. It's often used for complex defects where there's basically only one functional ventricle or where the right ventricle can't handle pumping blood to the lungs, effectively things like tricuspid atresia, pulmonary atresia, or severe stenosis.
Making the single good ventricle the systemic pump and letting blood flow passively to the lungs.
That's the idea. It's also used sometimes in conditions like hypoplastic left heart syndrome, where the right ventricle has to become the systemic pump. The Fontan handles the pulmonary circulation part.
Interesting. So it adapts the circulation. The source also mentioned truncus arteriosus briefly. What is that?
Truncus arteriosus is where instead of a separate aorta and pulmonary artery leaving the heart, there's just one single large artery, the truncus arising from the ventricles, usually over a VSD. This single trunk then supplies blood to the body, the heart, and the lungs. Surgery involves closing the VSD and creating a separate pathway for blood to get to the lungs, usually with a conduit.
Complex reconstructions. Okay, let's talk physiology again. Hypothermia, cooling the body, and metabolic rate. How are they linked?
It's a pretty direct relationship. Lowering the body temperature slows down metabolism. For every 1 degree Celsius drop in core body temp, the overall metabolic rate decreases by about 5% to 8%.
5 to 8% per degree. So if you cool someone significantly.
Right. If you cool someone down to, say, 28 or 30 degrees Celsius, moderate hypothermia, their metabolic rate is cut roughly in half, about a 50% reduction.
That's substantial, and that's why it's used clinically, to reduce oxygen demand.
Exactly. It protects organs, especially the brain and heart, during periods of reduced blood flow, like during complex surgery or after cardiac arrest. Less metabolism means less oxygen needed.
Makes sense. Okay, the intra-aortic balloon pump, IABP, how does that device work? We know timing is key.
Absolutely critical. The balloon sits in the aorta. It deflates very rapidly just before the heart contracts, systole. This creates a momentary vacuum, reducing the pressure the left ventricle has to pump against. That's afterload reduction.
So deflation makes it easier for the heart to eject blood.
Yes. Less work, less oxygen consumption for the heart muscle. Then, as soon as the aortic valve closes, marking the start of diastole, heart relaxation, the balloon inflates.
Inflation during diastole, what does that do?
Inflating the balloon pushes blood backwards towards the heart valves and down the aorta. This increases the pressure in the aorta during diastole, which is when the coronary arteries fill. So it improves blood flow to the heart muscle itself.
So deflation helps the heart pump out. Inflation helps the heart get fed.
That's a good way to put it. But the timing has to be perfect, synced with the ECG.
What happens if the timing is off?
Bad things. If it inflates too late, say after the P wave but before QRS, you lose the diastolic augmentation, the improved coronary flow. If it inflates too early during systole, like during the QRS complex, you're actually increasing the afterload, making the heart work harder against the inflated balloon.
So it could actually harm the heart if timed wrong.
Definitely. Worsens the oxygen supply-demand balance. Meticulous timing is everything.
Okay. Another topic related to heart workload. Afterload reduction in general, usually good, right? Lowering blood pressure makes it easier to pump.
Generally, yes, and things like heart failure or hypertension, reducing the resistance the heart pumps against is beneficial.
But the source highlighted a key exception. Which condition is that?
Tetralogy of Fallot.
Ah, the right to left shunt condition again. Why is reducing afterload bad in tetralogy?
Because in tetralogy, you have that VSD, the hole between the ventricles, and also obstruction to blood flow going out the right ventricle to the lungs. If you lower the systemic vascular resistance, the pressure in the body, it becomes even easier for blue blood from the right ventricle to shunt across the VSD into the aorta, bypassing the lungs.
So lowering body blood pressure makes the right to left shunt worse.
Exactly. It reduces pulmonary blood flow even further and worsens the hypoxemia. In tetralogy, you often want to maintain or even slightly increase systemic resistance to encourage blood flow towards the lungs.
Completely counterintuitive to the usual goal. Very important distinction. Okay, last main topic, protamine, the heparin reversal agent.
Right. Protamine is a basic protein, comes from fish sperm actually. It binds to the acidic heparin molecule and neutralizes its anticoagulant effect.
Standard reversal, what's the dose typically?
The usual guideline is about 1.3 milligrams of protamine for every 100 units of heparin given.
Are there any downsides or risks with protamine?
Yes, a few things to watch for. Interestingly, if you give protamine to someone who hasn't had heparin, it can actually act as a mild anticoagulant itself.
Weird. Binds to platelets or something.
Yeah, interferes with platelets and some clotting factors. Also, allergies can happen, especially in people with fish allergies or diabetics on NPH insulin.
NPH insulin, because it contains protamine.
Exactly. And maybe the biggest immediate concern is that if you give protamine too quickly intravenously, it can cause histamine release.
Histamine release, leading to low blood pressure.
Yes, potentially significant hypotension. So it needs to be given slowly. But the source does note there's no good evidence it directly weakens the heart muscle or slows the heart rate. No negative inotropic or chronotropic effects.
Good to know. So the main worries are allergy and hypotension from rapid infusion. Okay, wow, we have covered a lot of ground here.
We really have, from preventing infections like IE to managing complex things like HIT and bypass, understanding METs, congenital defects, the Frank-Starling curve.
ECG interpretation, PA catheters, IABP timing, afterload considerations, protamine. It's quite a tour.
It really shows how all these different pieces connect, doesn't it? Understanding the underlying physiology is key to applying these interventions safely and effectively. You see how guidelines evolve, like with IE prophylaxis.
And how delicate the balance is during critical events like bypass, with cannula positions, and venting.
and how fundamental concepts like Frank Starling or the effects of hypothermia underpin so many clinical decisions.
Absolutely. And hopefully for everyone listening, this deep dive brought some clarity, maybe connected a few dots without being too overwhelming, those aha moments we talked about.
That's the goal.
As a final thought, maybe consider how this intricate web of knowledge is always evolving. The constant refinement of guidelines, the better understanding of mechanisms like HIT or shunts in CHD, the technological assists like IEBP, it all points towards this ongoing effort to improve care by understanding the body's complex systems better.
It really does. It makes you appreciate the complexity, but also the progress. And how knowing these details, even something seemingly small like avoiding air in an IV line for a specific patient group, can make such a critical difference. It all fits together in the bigger picture of cardiac care.